Hi everyone, my name is Olivia, and today I'll be talking about Sizzurp with a focus on codeine. Codeine's chemical formula is C18H21NO3 and is naturally found in the poppy plant Papaver somniferum. It has been used as early as 4000 BC, and in 1806 morphine was isolated from opium. This allowed for the discovery of codeine in 1832. Codeine is administered orally and absorbed by the GI tract. Its maximum plasma concentration occurs after 1 hour of administration. Various enzymes metabolize codeine into morphine, norcodeine, and codeine 6-glucuronide. Metabolism mainly occurs in the liver, and around 90% of codeine is excreted by the kidneys. Codeine is a weak full opioid agonist and binds to mal-opioid receptors. This increases pain tolerance. Codeine also acts as a cough suppressant. It can also reduce nausea and diarrhea. Irresponsible prescribing of codeine, using without prescription, using with other substances, poor monitoring of dosage, hypermetabolizers, and not following prescribed tapering plans can all lead to addiction. Codeine has been used since 4000 BC as an analgesic. 1806, morphine was isolated from opium by Friedrich Serturner. In 1832, Pierre-Jean Robaquet discovered codeine. The creation of hollow needles, piston syringes, and hypodermic syringes made opioids more accessible. Sizzurp was developed in the 1960s and in 2000s labeled as a dangerous drug. Sizzurp is administered as a drink concoction, which consists of codeine, cough syrup, and antihistamines, which is mixed with soda and sometimes candy. Alcohol is also sometimes added. Sizzurp is popular in pulp culture and is often referenced in songs. Side effects include euphoria, dizziness, increased body temperature, and loss of consciousness. Codeine is nearly identical to morphine, with the only difference being its added methyl group on the 3-carbon hydroxyl group, which you can see in this photo. Codeine is a Schedule 2 to 5 drug and is administered orally via a pill or syrup. It can be administered intravenously, but that's very rare. Codeine is absorbed by the GI tract with a maximum concentration within an hour of administration. The metabolism of codeine occurs in the liver. Codeine is a prodrug, so it is inactive until it is metabolized. The CYP3A4 enzyme converts codeine into norcodeine. The UGT2B7 enzyme converts codeine into codeine 6-glucuronide. And the CYP2D6 enzyme all demethylizes codeine to convert it into morphine. The metabolites are excreted by the kidneys. Codeine is absorbed through the blood-brain barrier and binds to opioid gene protein coupled receptors. The alpha, beta, and gamma units dissociate and form beta-gamma component and an alpha component. Both of these components activate the potassium channels while inhibiting calcium channels. This reduces cyclic AMP, which then hyperpolarizes the neuron and inhibits it. The inhibited neuron is less likely to fire when stimulated, or releases lower amounts of neurotransmitters when stimulated. This blocks the release of glutamate, substance P, and calcitonin gene-related peptide, which then inhibits the pain signaling pathway. Codeine also binds to the brainstem, causing antitrusive effects in the hindbrain, sedation, and respiratory depression in the medulla. Some high-risk use behaviors include irresponsible prescribing of codeine by practitioners, not following tapering plans, using without a prescription, poor monitoring of doses, being a hypermetabolizer, which means that you have a duplication of the CYP2D allele, making metabolization of codeine faster, and using with other substances. Treatment plans mainly consist of trying to deal with withdrawal symptoms. This can include using methadone, buprenorphine, naloxone, and Codeine. Methadone binds to and activates mal-opioid receptors more slowly and stays within the system longer, giving the patients longer feelings of euphoria. Buprenorphine is a weaker version of methadone and can also block opioids from attaching to mal receptors. Naltrexone blocks opioid receptors completely. Clonidine binds to alpha-2 adrenergic receptors, which inhibits the release of norepinephrine, meaning that if a patient does use an opioid, they're not going to feel the feelings of euphoria. The retention rate ranges from 90 to 60% after 1 year when using a mix of methadone, buprenorphine, naloxone treatment. Cognitive behavioral therapy also accompanies these types of treatments. In Canada, the increase in mortality rates related to opioid use increased 91% from April 2020 to March 2022, compared to 2018 to 2019. Between January and June of 2022, there were 3,500 cases of opioid overdoses, and 97% of those overdoses seemed to be accidental. In the US, overdose deaths have increased from 3,442 to 17,029 from 1999 to 2017. 2016 to 2017, opioid-related deaths made up 2/3 of all deaths related to drug overdoses. So where should we go from here? Engineering a molecule which competitively binds to mal-opioid receptors without it being an opioid itself and not causing withdrawal symptoms would be an area of research that I think should be investigated. I also believe that testing for the CYP2D6 mutation before prescribing any type of opioids would be a good idea. While codeine is relatively low on the controlled substances schedule, it can still be very addictive after prolonged use. Alternatives should be considered before prescribing any type of opioid.